Em, Voy a dar inicio. Entonces, buenos días, bienvenidos, bienvenidas a nuestro conversatorio de la serie de conversatorios para la equidad. En el día de hoy, el tema que vamos a cubrir es sanación y reparación, elementos claves para alcanzar la equidad y la justicia social. Recuerden, como siempre, que tenemos interpretación. Para acceder a esta interpretación, deben ir a los iconos de Zoom que se encuentran en la franja de herramientas de Zoom. Hay un icono que es un mapamundi que dice interpretación y allí pueden seleccionar si necesitan interpretación en portugués o en español. Si quieren escoger portugués, por ejemplo, seleccionan el idioma y van a darle mute al audio original. Así solamente van a escuchar la interpretación en portugués. Lo mismo aplica para español. Esto es también desde el celular. Si están desde un equipo celular, pueden darle clic en los tres punticos donde dice más. Allí les va a aparecer la opción interpretación de idiomas y van a seleccionar también el idioma y asegúrense de darle silenciar el audio original. Quisiéramos iniciar también invitándolos a que observen el video del conversatorio anterior. Para esto ustedes pueden escanear el código QR que se encuentra en pantalla y de esta manera acceder al video de nuestro conversatorio anterior. Con esto le doy paso a Pedro o Jafet, no sé quién quiere cubrir esta parte. Pedro, dale, Pedro.
Y gracias, Nata. Oye, qué maravilla ver el grupo de gente que tenemos hoy. Muchos los vimos en Chile la semana pasada. Gracias por estar en Chile, gracias por estar presentes, gracias por el trabajo que hacen a diario por la equidad. De hecho, por ahí vi al Darío, y Darío, aquí tengo todo este equipo de la Fundación en Lisboa, en el Congreso Mundial de Hospitales. Un saludo muy afectuoso. Mira, hoy creo que es importantísimo, antes de pasar a contextualizar la conversación, y yo hago un comentario de nuestro invitado que es maravilloso, que comencemos con 10 segundos de silencio. Em, Vamos a hacer silencio diría yo, por el sufrimiento que estamos observando en distintas partes del mundo. Es un momento delicado y creo que tenemos una responsabilidad conjunta de tratar de seguir haciendo cosas buenas, con amor, con cariño, con calidez y por supuesto con fraternidad. Lo que nos une es nuestra humanidad y en eso creo que estamos todos absolutamente de acuerdo. Entonces, si podemos hacer 15 segundos de silencio al comenzar, simplemente para hacerle honor al sufrimiento que estamos observando hoy día y para comprometernos de nuevo en silencio a trabajar juntos por un mundo mejor.
Vamos fazer minuto de silêncio agora.
Bueno, y con eso, sol y luna, por supuesto, como es la vida, pasamos a tal vez de manera racional hacer un par de anuncios importantes. Jafet Arrieta, que está con nosotros, pues está con un título de trabajo nuevo, ahora es vicepresidenta del IHI a cargo de Trabajo en las Américas. Eso lo celebramos pues todos, fantástico, fantástico. Así que Jafet, felicitaciones. Y para darles un poco el contexto de lo que vamos a escuchar hoy, de la conversación, esta es una conversación siempre que vamos a tener, les voy a dar una idea de quién es Bram y por qué lo invitamos. Es poco usual que traigamos a alguien de un contexto que tal vez es un poquito más distante de lo que hacemos en cada día en Latinoamérica, pero de muchas maneras es similar. Bram es codirector del programa de Palestina para la salud y los derechos humanos en Harvard. También es instructor de la Escuela de Medicina y la Escuela de Salud Pública de Harvard. Es médico asociado en el Brigham and Women's Hospital y trabaja con Partners in Health como líder técnico. Bram además es Senior Fellow de Equidad, un grupo en el cual somos ambos, del cual somos ambos partes, del Senior Atlantic Fellowship for Health Equity. Y más allá de eso, Bram lo que ha logrado junto con su equipo, esto siempre se hace en equipo, es traducir las aspiraciones de equidad en cambios absolutamente tangibles y concretos que están cambiando la dinámica de una institución súper reconocida en Boston y en los Estados Unidos desde el punto de vista clínico y de investigación, a partir de un descubrimiento que fue una brecha de desenlaces de distintas poblaciones, particularmente diferencias entre población blanca y población latina y negra en su institución, en admisiones que tenían que ver con el tema cardíaco. Y a partir de eso se generaron una serie de cambios muy concretos, que están cambiando las conductas, la dinámica y los desenlaces. Eso hay que rescatarlo, hay que celebrarlo y tenemos que aprender todos juntos del tema, porque una de las brechas que todos en esta llamada seguimos viendo es el deseo de cerrar brechas de equidad y la dificultad de traducir eso en acciones. Este es un ejemplo absolutamente tangible de eso. Así que con eso, Jafet, te paso la pelota para que nos camines hacia la sesión.
Olá, Nata, você me ouve?
Muchísimas gracias, Pedro, y buenos días a todas y todos. Buen día, buenas tardes, boa tarde para algunos y algunas de ustedes. Gracias por acompañarnos. Antes de darle paso a Bram, y aquí pueden ver también su biografía un poco más detallada, queremos regresar y recordarles un poco, darles la bienvenida a esta serie de conversatorios. Este es nuestro sexto conversatorio. Tuvimos algunos meses de lapso entre el último conversatorio y queremos retomar y los estaremos retomando mensualmente. Sepan que si ustedes quieren ser parte y quieren estar presentando y compartiendo sus experiencias trabajando por y para la equidad, la justicia social en la región de Latinoamérica o en otras partes del mundo, este espacio es de ustedes, es una plataforma abierta, así que solo contáctenos y estaríamos felices de invitarles. Nata, si me regresas a la diapo de los valores, por favor. Queremos recordarles también, estuvimos hace unos días, justo la semana pasada en Chile con muchos de ustedes. Cuéntenos en el chat desde dónde nos acompañan y si alguien tuvo la oportunidad de acompañarnos en Santiago, en nuestro octavo foro latinoamericano de calidad y seguridad en salud, organizado en alianza con el hospital, con la Clínica Alemana de Santiago. Gracias por abrirnos esas puertas de su casa, y también con el Hospital Israelita Albert Einstein. Y como dijo Pedro, el enfoque del foro fue en la quíntuple meta, pero con mucha énfasis en equidad. Y justo en el cierre yo mencionaba que dependiendo de cómo veamos esa quíntuple meta, mejor salud para las poblaciones, mejor experiencia para las personas, mejor experiencia también para el personal de salud y por supuesto con un enfoque en valor para los sistemas, en eficiencia, en mantener costos sustentables. No podemos tener en cuenta ninguno de ellos si no ponemos equidad en el centro. No podemos hablar de calidad si no hablamos de equidad. Y yo justo en el cierre les compartía los valores de la IHI, que pueden ser la base, la fundación del trabajo que hacemos. Coraje, amor, confianza y por supuesto, equidad, de manera que nos sirvan como brújula conforme nos movemos hacia la quíntuple meta. Nata, si me das la siguiente, por favor. Y en ese sentido, retomando esta comunidad, solo recordándoles cuál es el espíritu, cuál es la intención de tener este espacio con ustedes. Si me das la siguiente, Nata, por favor. La intención es que precisamente utilicemos la ciencia de la mejora en servicio de la equidad, que nos movamos a la acción, ¿sí? que a una acción, a una solidaridad pragmática. Hoy el tema que va a estar cubriendo Bram es sobre sanación y reparación. Independientemente de dónde estemos en el mundo, estamos siendo impactados por tragedias, y realmente incluso la inacción contribuye a perpetuarlas. Entonces, queremos invitar a esta comunidad de personas pensantes, de personas comprometidas a utilizar las herramientas que tienen a su mano, y hoy Bram nos estará compartiendo otras, a movernos a la acción. Y ahí yo quiero destacar la importancia de pasar de la empatía a la compasión, porque la compasión denota e implica acción. Sé que muchos de nosotros, justo en la actividad que guiaba Pedro, gracias, empatizamos con lo que está ocurriendo a nivel local, en nuestras ciudades, a nivel local, en nuestras regiones, y a nivel local porque al final del día somos ciudadanos del mundo. La invitación, la provocación para todos y todas ustedes, y la invitación a hacerlo de forma colaborativa, porque definitivamente es más lo que nos une que lo que nos separa, es a movernos a esa acción, con la visión de lo que sabemos que es posible, cerrar brechas de equidad, construir sobre lo existente y de forma colaborativa. Y esta plataforma es precisamente eso, busca ser una red de aprendizaje, una red de acción y utilizar la ciencia de la mejora como elemento catalizador. Y entonces, con eso, para no tomar más tiempo de Bram, yo les voy a invitar a que vayan colocando sus preguntas, sus reflexiones, comentarios para Bram. Tendremos tiempo al finalizar su presentación para tomar algunas de sus preguntas, y para que ustedes nos cuenten cómo consideran que pueden aplicar algunos de los elementos de este marco conceptual que nos estará compartiendo Bram en nuestros contextos locales, anclados a ese trabajo que cada uno de ustedes hace en el día a día. Así que sin más preámbulo, le damos la bienvenida a Bram. Ya Pedro lo presentaba. Bram es no solo un excelente profesional, como pueden ver, sino además una persona que está comprometida con la acción y con esa misión de cerrar brechas de equidad. Así que con eso vamos a pasarle la palabra a Bram. Gracias por acompañarnos, Bram. Bienvenido.
Thanks so much, Jafet and Pedro, and to our interpreters and to all of you for being here. Really excited to be connected to all of you, and I do hope you will feel free to reach out to me afterwards if you want to continue the conversation or have any questions. I'm going to probably just speak here for maybe 15, 20 minutes about this case study from the hospital that I work in that's really been really an organizing movement. And, you know, while it's just me speaking here today, just to know that there's been a large group of people who continue to be involved that is making this possible despite even significant backlash. And so I just want to make that part clear, and then hopefully we can have a little bit of a conversation and discussion after that. Just to ground us a little bit here, while you know, I'm going to be talking about, there are many sort of forms of inequity, right, along lines like class, gender, race. I'm going to be focusing on racial inequity in health, and I'm specifically focusing on the type of inequities that are happening institutionally within our hospitals and clinics, right? Most of the injustices that drive differential health outcomes are driven by larger social forces and structural forces, but there are considerable inequities that are within the realm of our healthcare institutions. And as you can see here from this Institute of Medicine report from 20 years ago, or just 21 years ago, they're well known, right? And they were well known even then. And this report, they looked at all sorts of data to come up with the conclusion that even when members of minority groups, racial minority groups, have the same income, the same insurance coverage, the same medical conditions as white Americans, they receive notably poorer care. Biases, prejudices, and negative racial stereotypes may be misleading doctors and other health professionals. Unfortunately, unlike other movements that have led to dramatic changes, for example, in the quality and safety movement over the last couple of decades, there's mounting evidence that unfortunately not too much has changed in terms of addressing these inequities. You know, for a number of reasons, one of which is anytime there's new opportunities available, often those who are most privileged are best able to take advantage of them. And so with that kind of background, you know, institutions are responsible for many inequities in care that are happening. And unfortunately, this has been fairly stagnant for at least, the last 20 years. Moving now into the case study from my hospital, this is the medicine tower at Brigham and Women's Hospital, which dates back a few decades, as you can probably tell from this photograph. What we were noticing, those of us who were residents or trainees at the time, were that our number one diagnosis in the hospital is heart failure. And what we were noticing is that we were seeing heart failure patients in the medicine tower who were predominantly patients of color, Black and brown patients. Whereas in our specialty cardiology hospital that was new, where they had individual rooms and specialty trained nurses and family rooms, that's where predominantly the white patients with heart failure were going. So we had this suspicion as trainees, because we were working on both services, that in fact we were segregating care to some extent, right? And that patients, especially because socioeconomic status and race are in many ways collinear in the United States because of historical oppression, that we were noticing this pattern in how we were admitting patients in our hospital. It's something that only trainees could have noticed, right? Because the attending senior doctors were only working on one service or the other. We started to look into it, and sure enough, we found evidence that this was the case, right? So we found that about 2/3 of white patients went to the specialty service, while only about 50% of Black or Latino patients went to the specialty cardiology service. Even when we controlled for many factors that are influenced by structural racism, even when we controlled for those factors in a multivariable model, we still found differences, right? So there were things that we were responsible for that was driving this difference in where patients were being treated. We also know from old data from other institutions that this matters, right? That people get different care, they get better care, better outcomes in many cases when they're seen by a specialty cardiologist in this setting. And in our own institution, we found that patients who were in cardiology had fewer readmissions and better follow-ups. They got placed into care within the system in a different way. I'll also note that by leading with this racial equity lens, we also found other inequities along these fault lines in society, including finding out that women were also being discriminated against in our hospital and were less likely to be admitted to the specialty cardiology service. Okay, so this was just really one more example among many that have been found and listed in these reports of the kind of racial inequities that were being influenced by clinicians and by institutions, right? So this was another example of exactly what I had mentioned in that Institute of Medicine report. We did a follow-up study and found that our providers, our medical providers who are predominantly white, at a proportion above that in the general population of the city of Boston, were more often were perceiving that white patients were pushing more often to get into cardiology. And they admitted that when patients did that, they were receptive to that pressure from the patients. They also were more likely to call outpatient providers for white patients as well, right? So you could start to see how these interactions between patients and clinicians was influencing some of this inequity. And it's complex, right? It's complicated. This is what the providers were perceiving, but we don't know if it was real, right? And we don't know if it's also that white patients have been socially conditioned to ask for more, to expect more, to get more, right? To get better treatment. And then they pursue that in a different way. And that might be perceived in a different way as well. And so we realized that it was complicated and that there wasn't going to be an easy way to fix this. Sure, we could do education, and we did. Sure, we could do a number of different initiatives around, educating on racial equity, how it shows up in the hospital. But ultimately, we wanted something that would fix this issue for our patients more quickly and in a way that could address other problems we had. What I mean by that is that, for our patients of color, for our Black and Latino patients, This is an urgent issue, right? This is an emergent issue where they're not having equal access to care as white patients. And so we wanted to find a way to bypass, in some ways, the provider bias, but also to get at the question of trust, right? And when I say trust, I think actually the more important, right? Because mistrust and distrust of medical providers and institutions is a well-known phenomenon. But I think it's a little bit mischaracterized because it's much more, to my mind, about trustworthiness, because we know that these institutions from that old data, right, have been failing Black patients, right, and Latino patients in the United States for many, many years. And so it's not a problem of trust, it's a problem of trustworthiness of the institutions. And so we wanted to think what would be an intervention that could get at that trust question, trustworthiness question, in addition to fixing and even redressing and repairing the inequity that we had found. And so we put a proposal forward to say, we're not looking to do checklists, we're not looking to do colorblind or equality-based approaches to this. We want to think about, repair, redress. How do we actually think about the harm that has been done over years at our institution and what we're responsible for and accountable to? And so that's where we started thinking about deeper questions, moving outside of the realm of medicine and public health to think about how we could get to that repair-based element. Why repair, right? And again, I'm just to reiterate the point I just made. We're often taking trust for granted as clinicians, right? But if you consider the experiences, the personal experiences of racism that many of our patients have had, and when I ask patients of color, they often reply in the affirmative and can give very concrete examples of experiencing racism in the hospital. It makes a lot of sense, right? That they're not necessarily sure if they're getting the best care, if their best interests are being tended to. And so as you can see here, just how considerable that trustworthiness gap is. This is some data from the Urban and Commonwealth Fund, rather, that 7 in 10 Black Americans say they're treated unfairly by the healthcare system, and 55% say they distrust it, right? Which again is the problem on the side of these institutions and society at large that has led to this. And you can think of all sorts of examples of systemic biases and discrimination Black patients have faced, right? So what we did is we went outside medicine, we borrowed from scholars of reparations. We talked to legal scholars, we talked to policy experts, we talked to historians, we talked to anthropologists and sociologists. And what we realized, and we borrowed this framework that we call ARC, or healing ARC in our case, but what ARC stands for is acknowledgement, redress, and closure. And it's a model for the argument for federal reparations for Black descendants of enslaved people in the United States that's been put forth by economist Sandy Darity and folklorist Kirsten Mullen. And they wrote a book about this and have written many papers making the case for reparations for histories of slavery and also histories of legalized discrimination in the form of Jim Crow, et cetera, in the United States, and ongoing structural racism into the present. And their model of acknowledgement, redress, and closure, we felt was really something that spoke to us and the kind of racism we were seeing in the hospital, and that might be a model we could use in our specific case and potentially even more broadly. The acknowledgement piece, so the A of ARC stands for the acknowledgement, which is when the institution voices ownership and responsibility for these inequities, right? Not just sort of saying like, well, we found this and we might make these changes, but actually saying, we own this. This is our responsibility to fix it. And then second, to take a compensatory step in the form of redress or repair, to say, not just that we're going to try to fix this going forward, but we're going to consider the harm that's been done as we formulate the intervention and how to think about repairing that past harm. And finally, working with impacted patients and community members, Black and Latino patients from Boston and community members, to work towards closure, to have an agreement to say that, yes, we have instituted a new policies and a repair mechanism that we think is sufficient to be able to say that we now are confident that the system going forward is one that is equitable. What that meant in our case, and I'll talk a little bit more about that community involvement piece, is that because we had been denying equal access for Black and Latino patients to cardiology, specialty cardiology care, means that now if a provider tries to admit a patient, a Black patient or a Latino patient with heart failure, to general medicine, they'll get a pop-up that says, hey, we have this history of institutional racism. Your patients from a racial or ethnic group with historically inequitable access to cardiology. Please change the admission to cardiology unless there's no beds available or there's an overriding issue. And so we've been running this pilot for the last year and a half and have actually to date redressed about a little over half of the inequities that we documented from our 10-year study. So we're not only fixing the problem going forward, but thinking about the inequity we had done over that 10 years that we had documented. And that that was something that we worked on with our legal colleagues at the hospital, and I can talk more about that. But even the language we used to develop this mechanism and the process of, was this a fair way to consider redress for the inequity we found, we worked on with what we call a community wisdom council. And we worked with partners, racial justice partners that we are connected to through our health system, who work with community organizations throughout Boston to identify people who are active in health equity and racial health equity in Boston, right? So specifically Black and Latino activists and organizers and people who are working in health institutions and related institutions. We had people who worked on issues of prison abolition and other social justice issues to weigh in on what does acknowledgement look like, right? What should redress look like in this case? And are we building towards closure, right? And are we going to get there? So we wanted something that was very concrete, that could address our pilot issue, but also could be the type of intervention or the type of framework that could be used more broadly to address these issues in a way that not only addresses them going forward, but redresses the past harms and can start to chip away at the trustworthiness problem that we have as medical institutions that have propagated, institutional racism for a very long time. And so that was ultimately the journey we went on. There's lots to say about the challenges of doing that work in the hospital. Mm-hmm. And it's important to mention that, the final thing I'll mention is that when we came up with this plan and we put it out there publicly, and there were a couple different papers that came out, one with our chair of medicine saying that we own this. We've been inspired by the social movements that are happening around the movement for Black lives, and we are going to take this seriously and approach this. And when we also said we were going to use a reparation-based approach, there became a lot of backlash from neo-Nazi groups, from white supremacist groups in the US, this whole idea that the existing status quo system that was preferential for white patients might be jeopardized. There became a lot of backlash. And so I want to mention this just because today would have been Dr. Paul Farmer's 64th birthday, but actually the last thing he wrote, sadly a couple weeks before he passed, was and he wrote this actually while rounding on his phone in Rwanda, seeing patients. He wrote a piece, and then with colleagues Sheila Davis and Ophelia Dahl, defending the work that we were doing in Boston on anti-racism, and really calling out the forces that make this so difficult to do, even with a small pilot, right? And ultimately, we were not stopped. We've continued this work. We were able to build strong enough internal organization to withstand the pressures that happened, the death threats that happened, all sorts of different pushback that we got. and have been able to continue it going forward. And so we're actually going to be expanding it to 3 other examples that have been documented in our hospital. And there's a couple other hospitals that are using this healing arc framework to address these racial inequities that keep showing up as people do more research. So hopefully that gives some, I'll stop sharing my screen there. Hopefully that gives a little bit of, hopefully that was clear in terms of the type of intervention we've gone forward with and why. And, you know, we're still in the early stages, but, you know, I think our conversations with the Community Wisdom Council have been really powerful. And there's a lot of, I think, positive energy that this is something that, you know, could start to get at some of these deeper issues with regard to trust, and in terms of repairing some of this legacy of harm that our hospital and of course many others, if not all others in the United States, are implicated in. Thanks a lot.
Bram, you'll see, perdón, en español. Bueno, hay muchísimos comentarios en el chat. Creo que es importante que, Jafet, si te parece, que simplemente abramos el micrófono, ¿no? Y que veamos si hay alguna pregunta para hacerlo de una manera un poco menos caótica y, digámoslo así, anárquica. Tratemos de levantar la mano, pues simplemente para que las veamos. Entonces veo que Dianita en Perú levantó la mano primero. Diana, si quieres, abre el micrófono y haz tu pregunta. Qué bueno verte.
Ok, estoy muy contenta de estar en esta sesión. ¿En inglés, en Spanish?
Hazlo en español, que Bram tiene traducción al inglés.
Excelente. Súper interesante el tópico, muy puntual. Creería yo que una importante acción para corregir lo que ocurre serían decisiones políticas a nivel gubernamental. Ese es uno. Otro, la corrupción en Latinoamérica es horrorosa, horrorosa. Mi país, yo hablo de mi país, pero también sé de otros. Tercero, ya hablemos de Estados Unidos. Hay este grupo censurable que considera que lo que no es tez blanca es inferior. Y ayer mismo, en Lewiston, Maine, donde vive mi hermana y es catedrática, es docente de universidad, ha habido un tiroteo en Lewiston. Mi hermana vive en Bangor. Han muerto como 16 personas y hay como 52 heridos. ¿Por qué? Porque son de raza negra, porque son de raza amarilla, porque son mestizos, cobrizos. Es insólito. Tercero, y lo leí cuando revisé inequidad en salud de la mujer, trata de blancas. No podemos cegarnos los ojos. Trata de blancas es un problema importante. Personas de nuestros países latinoamericanos viajan a Europa, a Asia, para trabajos forzados y denigrantes. Y en muchas otras situaciones, también gente que está escapando de guerras, gente que fuga. Luego, otra cosa importante que lo leí, no solo en Latinoamérica y fuera, en Estados Unidos, personas que no tienen seguro. Y si a la vez, porque no son nacidos en Estados Unidos, luego viene el que se nacionalizó y luego viene el que no está nacionalizado y es como un inmigrante ilegal, no tiene seguro. Y encima había otro cuadro más interesante, que es inmigrante legal y de bajo poder adquisitivo, pues el panorama era peor y los porcentajes de no insurance eran muy altos. Tercero, ¿qué pasa cuando a un mismo trabajo a las mujeres le pagan menos? ¿Y por qué? ¿Por qué si tenemos las mismas neuronas y el mismo desarrollo intelectual? Eso es no permitido. Son unos puntos que quería tocar y que escucho su respuesta.
Yeah, I mean, I think you touched on so many of core inequities that are really shared across, you know, the Americas, you know, certainly. And I think my deep view is that, and I think this is really borne out, right, when you look at even from the CDC or the WHO, all of these, you know, in the United States or, you know, in the US or globally, right, what we understand is that the majority of health inequities are ultimately driven by these structural and political forces, right? These historical forces, these societal norms and forces, right, that are inequitable. And you mentioned many of them. And I do think ultimately those are the most important things to change and shift, and moving the needle even a little bit there gets us much farther along than what we can do ultimately within, the institutional realm of delivering healthcare, right, at the hospital level, in my case, or at the clinical level. And yet there still are these same forces are operating at that local level, that downstream level as well. And so, that's what we wanted to do. We wanted to say, well, we have this understanding, this structural upstream understanding, but we still want to try to make a difference where we are now with our patients, and to at least to name these things and to try to do what we can in this place while still advocating at that larger level. But I think, and hopefully, I was clear on that too, because I'm with you in that I think ultimately this is a small part of where we can actually address the issue, and especially if you think about a society as unequal as the United States at that level. But yeah, I think there's so much work that needs to be done there. Thank you for that.
Gracias, Diana, por comenzarnos. Y una de los esfuerzos que hemos hecho proactivamente en este conversatorio es, por supuesto, darnos cuenta y tomar en cuenta las dificultades contextuales, digámoslo así, a nivel macro, y tú mencionaste muchas, Diana. Pero muy especialmente enfocarnos en lo que nosotros podemos hacer. Y Jafet y yo queremos, y Nata y el equipo de IHI, enfatizar que todos nosotros tenemos un rol importantísimo en cambiar esta realidad, y que la acción puede ser inmediata. No estoy hablando del impacto, sino de la acción, el deseo de saber más con los datos, el deseo de probar cosas distintas, el deseo de abrir la puerta a conversaciones distintas. Ese tipo de cosas creemos que está al alcance de las manos de todos nosotros, y tratamos de enfocar todas las conversaciones que tenemos en ese tipo, digámoslo así, de problemas, y aceptarlos, y de soluciones, y probarlas. Entonces, Jafet, no sé si quieres tomarlo desde acá y le pasamos la palabra a Darío después de escuchar.
Buenísimo, mil gracias, Pedro. Sí, yo creo que es muy importante poner las cosas en contexto, como bien decía Pedro, como bien aludías de Anita, entender cuáles son esos determinantes estructurales, sociales, pero también acercarnos más a lo que sí está en ese locus de control nuestro, en lo inmediato. Siempre hablamos en el IHI de qué podemos hacer para el próximo martes. Yo les diría qué podemos hacer hoy distinto para cambiar esas realidades, de las cuales ciertamente, al menos en las personas que estamos aquí, hay un reconocimiento. Darío, te vemos con la mano levantada. Cuéntanos.
No, me parece una conversación maravillosa, y yo quisiera entender un poco de Bram cómo funcionó dentro de la institución, porque yo creo que ese es un elemento súper complejo, digamos, ese inicio del trabajo en los lugares.
Such a good question. And in fact, one of the, and we made a lot of mistakes along the way. And one of them that was early on was that those of us who were looking into this were all within the internal medicine department. But a key, department involved in the triage process, and the most important, is actually the emergency medicine department. And we're fairly separate groups. And so what happened is we started looking into this, and by the time we kind of found the preliminary results, then we reached out to the emergency department to let them know. And they were very, very unhappy that we hadn't started talking with them earlier. And there was a lot of tension. And my colleague and dear friend, Dr. Michelle Morse, really led a lot of meetings just to kind of start working with everyone to be like, we think this is an institutional issue. It's no one's pointing finger at one or the other. We're all part of the problem, and we all need to be part of the solution. And so she led every meeting at the beginning with just some basic concepts of like, what do we mean by, institutional racism, right? How does that show up? What what is race actually in the medical environment, and building from there. So we started getting a shared understanding of the problem and what the issue was. And we essentially, through these meetings, and we started inviting more people in, and then eventually the chairs of emergency medicine and internal medicine to talk about this. And there were a lot of like atypical things that happened. You know, we gave the data to many different people instead of just kind of keeping it to ourselves, and everyone looked at it. So we were all in agreement. And we sort one by one kind of went through the hospital to actually convince people that not only is it okay for us to publicly go forward with this as a single center study, but in fact, it gives us an opportunity to own up something that, you know, all hospitals are dealing with, and to say that we're going to try to make forward movement on this. And through those kind of conversations, we were eventually able to convince, you know, people who were pretty high up in the institution that this is something worthwhile that we want to do. And even then, when the backlash came, we had built a large enough community through these organizing initiatives in the hospital that even though some folks maybe shrunk away from that kind of intensity of backlash that happened, ultimately we were still able to, we had built enough power within the institution that we could still move forward. So I think, though, you know, I should have probably spoken about that more, because in many ways that was the most important piece, because, you know, I've seen other initiatives fall apart, and I think it was that kind of work that made it possible and still makes it possible, because it's not without controversy even within the institution today.
Gracias, Bram. No veo más manos arriba, pero veo algunas preguntas más en el chat. Ah, Darío, la mano se quedó arriba porque tienes otra pregunta.
No, es que
Cuéntanos.
quiero preguntar un pedazo más, y es, ¿qué pasó con la administración? ¿Cómo se comportó la parte administrativa respecto a esta iniciativa? Porque en algunas oportunidades puede ser uno de los stakeholders más difíciles.
Yes, that was a really good question. And to some extent, once we got our department chairs on board, we were a little bit protected. But what ultimately happened, for example, when there was and you know, a lot of authority rests at that department chair level, and so we were able to go forward with the project without it necessarily reaching the level of this of the C-suite in the hospital. But when there was backlash, then everyone heard about it, because the hospital was flooded with phone calls. There was even a bomb threat at one point, and there was really significant, you know, a neo-Nazi group from New England came and picketed outside in front of the hospital, and then everyone knew about it. So that the first wave of backlash, actually there was a little bit of, there was some distancing, right? They sort of took this approach of like, well, this doesn't necessarily reflect the hospital, like these are just, you know, two people. But ultimately we then started having conversations about, with them about it, about what it felt like to be sort of abandoned in that way, and also just to speak very frankly about, again, the motivations and the, you know, or basically the philosophy behind what we were doing, right? And the importance of this, from this question of patient equity, patient safety, patient trust, all of which, you know, were significant issues that we needed to address. And so I think once we had that opportunity to talk about that, to explain why we were doing this approach in a what we called a race conscious manner, you know, ultimately what happened then was when it came time to fund the project, because some of our other funding was not available because there was so much backlash that then the president's office, ultimately of the hospital, the CEO's office, essentially took over funding directly. And so then we had, you know, even financial support at the highest level. But it again took a lot of sort of conversations and convincing.
Gracias, Bram. Gracias, Darío. Dianita, te vemos con la mano arriba, pero vamos a tomar un par de preguntas más del chat que se están generando algunos elementos en común. Bram, te voy a hacer las 3 preguntas que he podido resumir y las podemos tomar una por una. Una de las preguntas es y comentarios sobre la importancia de la educación intercultural, pero también sobre sesgo implícito, implicit bias, al personal de salud como un mecanismo para hacer frente a esa atención inequitativa, desigual a pacientes. Hay otro comentario importante sobre el tema de la interseccionalidad. Nos dicen en el chat que, bueno, tú hablabas de racismo y en Latinoamérica se reconocen otros ismos, incluyendo el edadismo, clasismo, sexismo y algunos otros. Entonces, si pudieras hablar un poco de eso. Y perdón, pero ya que tengo el micrófono y veo que hay otra pregunta muy relacionada con lo que tú presentabas, y es el tema de si hay algunos indicadores que se pudieran seguir en el tiempo para ver el impacto del arco, por ejemplo, que tú presentaste en términos de restablecer, de restaurar lazos de confianza y algunos otros elementos que se pudieran medir. Hay más, pero las llevamos en partes.
Those are really good questions. And I'm actually already forgetting the first one. I know the second one was about intersectionality and the third one about the indicators. Can you remind me, Jafet,
Implicit bias, training around
implicit bias.
Implicit bias.
Perfect. So I'll go in order. I think that's crucial. And what we kind of realized, though, was that that's a longer term game. There was a study published last year that shows that you can sort of you can sort of bypass it, through patient activation. So they've done these sort of a study where they had actor patients, and essentially you can if you can have a provider in the moment remember something, and that was the idea behind our intervention as well, which is one idea in the short term is to kind of be like, hey, remember, we have these inequities as an institution, and then it sort of puts it to the front of your brain in a way that you can respond. But I think, a larger, political education and education is so important. We did do series of video trainings that everyone in our hospital had to do on race and racism. So that was and that was partnered with Dr. Kamara Jones, who's an expert. And we did a number of talks within our various departments as well. So I think trying to keep it front of mind as much as possible is one way, I think, to mitigate that. And we've seen that more and more now with studies as well. I think I'll go to the indicators one next. I think certainly just asking folks, right, and what we're trying to do now is to do more interviews and to do more surveys of patient experiences, and to not be thinking only in these like hard clinical outcomes, which are of course important, but also what are the experiences patients are having, right? And are we building trust? Is this making a difference? So I think there are definitely some surveys that have been developed, and we're working on this now with another project to do that. Outside of that, I don't know of any other ones off the top of my head, but there's a discrimination-based survey that David Williams from the Harvard School of Public Health has developed and updated over time that we're using. And then, I think the intersectional piece is so important, right? One of the challenges in the US case is that oftentimes people fall into camps of sort of identity essentialism or class reductionism. It's like all, racial identity, right? Or it's all, economic class context. And of course these, and as you mentioned, ableism, age, gender, sexual orientation, all of these different things are also influencing at different levels. And I do think, I think it's crucial, right, that we find ways to address this. We, in our project, ultimately have only really looked at the one axis, but I think continuing to sort of iterate on these themes is crucial.
Gracias, Bram. Definitivamente mucho interés en el chat de aprender sobre acciones concretas que se puedan adaptar, por supuesto, al contexto local. Hay algunas otras, voy a hacer una pausa para tomar el comentario, pregunta de Dianita, y regresamos a algunas preguntas más del chat.
Puntual, dirigida al hospital. Ok, entonces, el jefe de consultorio externo del departamento es muy feliz cuando vemos muchos pacientes en una hora. Y la flecha sube, sube, sube como una bisectriz y él es muy feliz. Y el director lo felicita. Vamos por partes. ¿Será acaso que ese doctor al cual se le premia porque nosotros, no esclavos, pero nosotros los doctores, vemos pacientes en una hora en un número mayor, pero se ha preguntado cuál es la calidad de atención que le damos a ese paciente? ¿Cuál es el número de reingresos que tienen esos pacientes? Concretamente, hoy en día hablamos de enfermedades crónicas no transmisibles que son una epidemia. Diabetes. ¿Qué pasa con diabetes y depresión? Hay una flecha bidireccional. Yo deprimido puedo llegar a tener diabetes. Yo diabético puedo llegar a tener depresión. Entonces es un insólito que nosotros en consultorio con el paciente no evaluemos la salud mental, porque nosotros mismos nos ponemos una zancadilla. Porque si el paciente se va con su mejor metformina o con su mejor antidiabético a su casa y no hemos evaluado la salud mental, ese paciente, si está deprimido, no hay adherencia al tratamiento. Al no haber adherencia, se descompensa, regresa al hospital, pasa al pabellón de hospitalización, si no a la UCI, y luego muere. Entonces, ¿dónde está la racionalidad de ese jefe de consultorio? ¿Y por qué no se instaura un tiempo un poquito más prolongado a adulto mayor? ¿Y por qué no se hace un estudio de economía en salud, costo-beneficio, costo-utilidad, en la cual se ve los años de vida ganados por calidad de vida? Y se ve que más vale invertir en un poquito de tiempo y no ver tantos pacientes en un día, luego podemos poner otros horarios, sábados, pero no hacer a la carrera loca y luego tener reingresos y haber más gastos, y eso es un trabajo sin eficiencia. Escucho.
Gracias,
Now you're really speaking my language, Diana. Much of my work is in with community health workers in Palestinian refugee camps, actually, and focusing on diabetes, but also trauma-informed mental health, and this endemic of the way these feed into each other, right? Mental health and diabetes, right? And these multiple things is so important. And it's something that I, as a physician who sees maybe a patient with diabetes for 1 hour a year, can't ultimately influence, right? And that's the beauty of thinking about a wider, range of approaches, community health workers, et cetera, to try to have a system that can actually start to deal with these issues and the quality piece that you speak of. So I'm 100% with you. I wish our health systems were built in such a rational way, in such a humane way to address these problems. And I think, I would love if other folks have ideas on that too, but I think you're getting to the heart of some of the problem where, the tensions between, economic productivity and efficiency versus what is really needed for folks in order to get on the road to health and in that way. So I'm with you. I wish I had answers.
Jafet, antes de que terminemos, simplemente para felicitar la participación de hoy, yo creo que de los conversatorios que hemos tenido es de lejos el más activo en el chat y especialmente activo con un sentido de pertenencia hacia la acción. Así que lo felicitamos. Esperamos que esta conversación continúe, por supuesto, hacia el próximo conversatorio y los invitamos a eso, a tomar acción basados en el amor, fundamentados en la ciencia, con un sentido profundo de fraternidad, porque eso es lo que estamos haciendo en estas llamadas, en estos conversatorios. Bram, a ti, bueno, no sé cómo darte las gracias por todo lo que estás haciendo, tú, tu equipo, por el amor que inspiras cuando hablas y por el coraje que han tenido de no detenerse. Así que un abrazo grande de nombre de todos nosotros. Y Jafet, te tiro la pelota.
Gracias, Pedro. Bueno, tal vez antes de cerrar, no sé, Bram, si haya un mensaje con el que quieras dejar a este grupo que seguramente querrá seguir aprendiendo de este arco y de todo lo que están haciendo ustedes para adaptarlo al contexto latinoamericano, y un mensaje orientado a la acción. No sé con qué palabras te gustaría dejar al grupo.
Just thank you. And again, please feel free to reach out. You can share my email if anyone has further questions. I'm always happy to talk about these topics. I'd love to hear what other folks are doing and what challenges they're running into. So thanks again.
Muchísimas gracias. Gracias, Bram, por acompañarnos, por compartirnos algunas herramientas, por compartirnos ejemplos concretos de lo que se está haciendo, incluyendo los retos que ustedes han tenido en el Brigham, pero también destacando cómo esa experiencia del Brigham les ha llevado a desarrollar un marco conceptual que esperamos que muchos otros puedan adoptar y adaptar a sus contextos, y este marco que además está enmarcado en dos conceptos muy, muy bellos, de sanación, de reparación, y esa sanación y esa reparación comienza a nivel local, así que queremos dejarles a ustedes hoy, gracias por acompañarnos con ese mensaje, el mensaje y algunas herramientas de nuevo para buscar en ese camino que nos lleva a cerrar brechas de equidad en nuestros contextos, la sanación, la reparación, y hacerlo. Hoy Bram mencionaba a Paul Farmer, mentor que tenemos en común, que en paz descanse, y Paul siempre nos invitaría a abrazarlo, abrazar estos temas con un espíritu de solidaridad, y solidaridad pragmática, es decir, solidaridad que nos mueva a la acción, que nos mueva de esa empatía a la compasión y a la acción. Y entonces con eso yo les dejo con la pregunta con la que siempre cerramos: ¿qué compromisos se llevan hoy con base en lo que escucharon, con base en lo que leímos en el chat, con base en lo que compartieron algunas otras personas? ¿Qué compromisos se llevan hoy para continuar trabajando, para cerrar brechas de equidad en sus contextos? Ese es el boleto, el ticket, como decimos en Latinoamérica, de salida de hoy. Les estaremos compartiendo la grabación, por supuesto, las diapositivas, los materiales, y nos vemos en un mes. Ya también les compartiremos las fechas de nuestro siguiente conversatorio. Y conforme salen, también les agradecemos si nos ayudan a completar esta encuesta, en la cual hay un espacio para que ustedes sugieran algunos otros temas, o si ustedes quieren esta plataforma para presentar su propio trabajo, es de ustedes y es para ustedes. Muchísimas gracias, y nos vemos en un mes. Muito obrigado. Thank you so much, Bram. Thanks, everyone. Gracias a todos y todas.
Thanks so much. Bye, everyone.
Muchas gracias. Excelente, excelente.
Gracias. Thank you.
Muchas gracias.